All right, well, welcome everyone. Good morning or afternoon. Thank you so much for joining us for what promises to be a very insightful session. We're very excited to bring you this topic today, compliance for CMS signature requirements. We know this is an important topic that can be complicated, and so we're exceptionally fortunate to have brought an expert for this topic today. Joanne Byron is the CEO and board chair of the American Institute of Healthcare Compliance. Joanne brings knowledge and experience that will be invaluable to us today. So just really quickly before I hand the floor over to Joanne to introduce herself and get our program started, just let me cover a few logistical points. First, as you probably all are aware, this presentation is being recorded, and a link to the recording will be made available to all attendees or anyone that registered and wasn't able to attend shortly after we conclude our session today. You will also find a link to download the presentation slides in our Q&A at the top of the Teams options there. And then also please utilize that Q&A feature for any questions that you might have for Joanne throughout the presentation. And we'll do our best to address all of those questions, or as many of them as possible, at the end of the presentation today. So with that, I'd like to turn it over to Joanne to get us started.
Hey, thank you, Denise. Well, welcome everyone. I know how busy you are, and I appreciate the time that you're taking for today's presentation. What we're going to be talking about is for educational purposes only. It's not consulting or legal advice. If you have concerns about meeting signature requirements and compliance, consult with a professional for some advice specific to your type of organization and your needs. Denise already introduced me, and I have a nursing background, a Bachelor of Science degree, and I'm also a certified coder. I'm certified as an investigator, auditor, and in a few other areas, including HIPAA and documentation requirements. Also, my organization, the American Institute of Healthcare Compliance, we are a licensing and certification partner with CMS. So I'm very honored to be able to present to you today about CMS guidelines. Today's agenda, first we're going to talk about why authentication matters and what signature guidelines there are that need to be followed. We're going to review industry compliance standards and what the authentication guidelines are that you need to be aware of. Also, how to avoid pitfalls and failures from what other people have done. And I'll share some of my CMS auditing experience with you on things that I have found so that you can make sure that you're not making the same types of mistakes that may have gone undetected. We're going to talk about how to apply CGS, Noridian, and other CMS Medicare Administrative Contractors, or MACs, and their authentication requirements in the event that you undergo a medical review or an audit. And then we're going to talk about remedies. There are certain things that if you don't meet all of CMS's requirements, they allow signature logs, attestations. And we're also going to end with how to develop an e-signature authentication policy that if you're using electronic records, CMS auditor or CMS contractor could go ahead and request that. And if you don't submit it, they can deny the claim. So it's very important that you have that if you have an EHR. So why is this topic so important? Authentication compliance typically isn't a priority for most workforce members. However, as an organization, it should be at the top of your compliance issues because suspicious or missing signatures and not meeting authentication guidelines could lead to an investigation. The Centers for Medicare and Medicaid Services, they do publish guidelines specifically for Medicare review organizations. Now, these Medicare review organizations are called Medicare audit contractors, and they follow the recommendations for that Medicare publishes in their Program Integrity Manual. Specifically, it's Chapter 3, Section 3324. This is available to the public. You can download these guidelines. They get updated occasionally, but you can go in periodically to see if anything has changed. And the link, when you get a copy of the slides, is on this particular slide so that you can click on it and download it and reference it. We're also going to talk about Section 3325 as well for amendments and corrections in just a moment. Now, there are a lot of acronyms, as we all know with healthcare. It's like alphabet soup. And the Program Integrity Manual, which I call the PIM, is applicable to Medicare Administrative Contractors, but also the UPICs, which are the Unified Program Integrity Contractors, Supplemental Medicare Medical Review Contractors, or the SMRCs, I call them, and the CERTs, the Comprehensive Error Rate Testing, as well as the RACs, the Recovery Audit Contractors. So let's go and look at a few specifics. In this CMS Program Integrity Manual, it states there are two distinct purposes. The first one is to satisfy specific requirements according to statutes, regulations, and national coverage determinations, or NCDs, or local coverage determinations, which are now in articles, and to resolve authenticity concerns related to legitimacy or falsity of the documentation. We want to remember that medical records, they're a legal document, and falsifying or creating a record that does not accurately reflect what was done, and somebody signs that person, whoever signed that note, is responsible. So we want to make sure that none of our documentation and our signatures look suspicious. You want to be above reproach. Now, when a Medicare contractor, such as any of those that we talked about, the UPICs, SMRCs, and CERTs, they will direct their concerns of any legitimacy of the documentation to somebody called the UPIC, the Unified Program Integrity Contractors, and those are the ones that come in and do an investigation. So if you get a request for records from a UPIC, you need to respond timely. You probably should consult with your compliance officer, make them aware that a UPIC has requested records. You want to take a look to make sure all of your documentation looks good and that everything is appropriately authenticated. So let's take a look at the Program Integrity Manual, specifically to 3325. CMS and other payers, they all realize that there's going to be times when you maybe didn't have all the information at that moment when you had to close out an encounter and authenticate it. So when there's an amendment or an addendum or a delayed entry needed, CMS expects you to have that done appropriately according to their guidelines. So you don't go in and close and lock a record and then reopen it, alter it, and lock it again. That looks suspicious. You need to make sure that all of the notes are signed, dated, and if there's any changes, that they're clearly and permanently denoted in the record. If a record is not appropriately amended or corrected, CMS again directs the contractor to suspect a potential fraudulent entry and refer the case for further investigation. So as you can see, CMS really sets authentication standards for the healthcare industry, and a lot of other major payers adopt these guidelines as well. I want to warn you, as a person that has done consulting and has represented organizations, DME companies, home health, hospices, practices, and hospitals. When they ask, they being a MAC or a Medicare contractor, Cross Blue Shield, Aetna, or any other major payer, when you copy those records, don't put any erroneous markings on those records. Those records are copies, yes, but any erroneous marks, they're going to say that somebody tried to alter the record, even though you're trying to explain. So if you have any issues that you want to explain to the person requesting these records, you're going to do it in a separate letter and state on page 1, second paragraph, second sentence, it may be illegible. Here is what it states. Or I want to direct you to this part of the medical record that supports medical necessity, and it was signed off by such and such a person. Don't mark on the records that you're submitting. So let's begin our review of industry compliance standards from two sources: CMS's general signature requirements first, used by Medicare audit contractors, and guidelines specific to home health and hospice medical review signature guidelines. By prioritizing compliant authentication, your organization can enhance patient safety, improve quality of care, and ensure compliance with relevant regulations and accreditation standards, such as those that you have to meet with CHAP. I do want to go over something briefly about DME. If you are from a DME organization, there are additional signatures that you need to be aware of. When it comes to any justification for an order, also you have to look at patient signatures. There's different types of documentation, but any signature that is required for payment for your service, you want to make sure that if you are doing any internal auditing, you look at all of those signatures, not just signatures from within your own organization. So I know you learned this all in your training, but if it isn't written, it didn't happen. If it didn't happen, you can't bill for it. And if it isn't written, the entry doesn't count if it isn't properly authenticated. So it has to be, your records need to be kept according to what Medicare calls record keeping standards or principles. When an entry is made, and it could be a little scribble in a margin, and it isn't signed, you can't bill for anything that isn't authenticated. So filing a claim without authentication, supporting the documentation for the claim that's filed, is considered a false claim under the False Claims Act. So let's review the more common pitfalls found during routine audits done by payers or auditors like me if I come in and I'm doing an internal audit to help you with process improvement. Some of the common pitfalls: illegible signatures, signed, but there's no credentials. Credentials are very important because the payer needs to know that whoever made this entry and provided this service, are they qualified? Are they licensed to be able to do this service? And then signed but not dated. We need to know the date the signature was applied, or no signature at all. And that's definitely an issue. Should never have billed for it. An unclear signature, that can cause confusion about who wrote the document or the note, and it hinders what's called accountability. Worse is no signature, or the signature is present and no credentials, and it's not dated, because it shows that the person that made the entry is neglecting their responsibility as a professional, and it leads to incomplete records that's just not going to pass inspection from any regulatory body or payer. Hopefully, your organization has strictly enforced the policy of never sharing passwords or login credentials to your medical record system or any computer system. Signatures provide a clear record of who made that entry. And it's medical records, because they're a legal document, they can be used as evidence in legal proceedings. So no signatures really can cause a legal issue for malpractice and as well as for reimbursement purposes. Also, if you share usernames and passwords and other people can get in and pose as you, there's a way that computer systems can track who accessed what types of records. And that not only violates HIPAA regulations, but it can result in penalties and fines. And it's also falsifying a legal document. Medical records need to be held at a very high level of security. We need to be able to depend on it as reliable information for patient treatment. And then when you forward those records to other caregivers, they're relying that the information is complete and accurate and true, and they know who signed off on those notes. So there's a coordination of care. I was involved in a case under an attorney-client privilege situation, and the payer was not Medicare, but they accused the practice of over $2 million in fraudulent overpayments. Now, during our internal investigation to try and find out what was happening, so I could tell the attorney what type of defense to build, we found that the doctors didn't want to take time to document their notes in their electronic system. Now, you can have a scribe, but there are certain requirements. Scribes are in the room with you. So what happens when the assistant checks the patient and leaves the room? The doctor comes in, does the treatment plan, does everything they need to do, walks out, and then hands a little card to the medical assistant, who then turns around and logs in using the provider's username and password and has a little checklist and clicks and auto fills treatment notes, and then closes it and locks it as if the doctor made that entry. That's an issue. It doesn't meet the requirements of a scribe, and a scribe is not going to be logging in as the doctor. The doctor logs in, the scribe does the scribing, and you can denote that that was a scribe, but the doctor or the person who's responsible for rendering the service needs to state that they have reviewed and everything in the note is accurate. And then when they authenticate it, it is saying that it is accurate and true, and they're taking responsibility for it. So the moral of the story: never let anyone make an entry for you. Never use someone else's login credentials. AutoPen, auto authentication. We all know the big hubbub at the White House about AutoPen with the last administration. You don't need a hubbub about that in your organization. So if you have an external party coming in, you want to make sure that any auto authentication or auto signature systems, they don't allow you to review entries before signing. That is considered unacceptable. We want to make sure before you auto apply your signature that you have the ability to review it, to make sure it's clean, clear, complete, accurate, and then the signature is applied. Documentation that says signed but not read, CMS will throw the whole document out. Signed but not read shows that there was no responsibility by the person authenticating the note to make sure that the note was accurate and true. So that's going to lead to an overpayment. When a note is scribbled in the margin or printed in the margin, it needs to be signed or at least initialed, because otherwise it looks like an erroneous marking and looks like somebody attempted to falsify the information. But sometimes it could be pertinent to a piece of information that's needed for payment. So you want to make sure that there's no unsigned, typed, or handwritten scribbles or notes. And if there are, you need to train your staff to always initial and or sign. Statements like signed by, followed by a typed name that is part of the transcription. This indicates the transcription service, not the provider, added the signing information. So they're going to throw the note out. It's invalid. Generic statements like this document has been electrically signed in the surgery department. That isn't going to count without a specific provider's name. This type of statement does not identify the responsible person who rendered the service, and it's considered inappropriate. Documentation stating only dictated by without a provider signature indicates that the note was not necessarily reviewed and approved by the provider. So we want to avoid these kind of pitfalls. So I'd like to spend some time now discussing best practices. Regular auditing of documentation practices is the best way to measure where you are right now with your authentication policies, procedures, and how compliant everyone on your workforce is that has the responsibility and the authority of making an entry in the patient's medical record. So the first recommended strategy is to have an efficient audit program that includes auditing for valid compliance signatures within your own documentation. And then when a referring provider's document is required, by many of you, you require orders or you require progress notes from somewhere else. You need to make sure that their signatures are in place. Your reimbursement is contingent on having everything in order and everything properly authenticated. So you want to make sure you include not just your own signatures, but any other documents. By doing regular checkups, you're going to identify weaknesses in signature practices and identify what corrective measures are needed. And it's almost always a training issue, going over here's what happened, here's how we need to do it going forward, and to take a look to see if there's anything that you can do to remedy historical problems in the event of an audit. You want to utilize audit results to focus on the training to correct root causes. If you don't get down to the root cause, it's just going to pop up. If it's just like putting a Band-Aid on a festering boil, it's just going to keep festering. So regular training is important to teach about proper documentation techniques, the signature requirements, and not only to new workforce members during onboarding, but you want to do it on a periodic basis, at least annually with your staff. If you're finding that you're doing little partial routine audits, monthly staff meetings saying, hey, we came across an issue here. We all have to remember to do better by following our policy and doing A, B, and C. By bringing attention to it, when people know that they're being monitored and measured by a performance issue, they're going to tend to pay attention to it. If management isn't finding that issue important, nobody else is going to look at it as being important. Your management team should serve as role models and support company training sessions. We need to stress the importance of signature compliance because it serves as a safeguard for patient safety, quality of care, and legal compliance. Emphasize during your management workforce training programs how compliance signatures ensure accountability, accuracy, and verification of the documentation that ultimately contributes to better patient outcomes and your company's reputation. As healthcare providers, it's important to create and communicate clear policies about signature requirements. This includes specifying acceptable uses of the copy-paste function that you might have if you're using electronic records, and detailing when signatures are necessary. You want to promote awareness of policies that's going to aid in maintaining compliance. And it's extremely important to train workforce members to have responsibility of sending any documentation out as it relates to coordination of care, providing supporting documentation, such as filing an appeal on a denied claim, to have the ability to recognize what an inappropriate signature is and to bring it to a supervisor's attention before sending it out. So creating clear policies and procedures is going to bring success to your training sessions. Standardization reduces variation, which results in reduction of errors. So this can also apply to signature compliance as well. You want to standardize it. Utilize technology to reduce signature-related errors and improve documentation accuracy. Advanced EHR systems with features for electronic signatures that can facilitate this signing process and ensure easy access to signature fields that can prevent the omission of important signatures. And managers may also use tools that verify staff training on signature policies to help reinforce adherence to best practices. Artificial intelligence and those AI-powered tools, it's might be new to your organization, but there are some tools out there that can analyze medical records to find missing signatures, and it can flag incomplete entries. It can automate and streamline your auditing process to find out how big of a problem authentication is or isn't in your organization so that you can address it before it becomes a compliance issue. Appropriate signatures is crucial for patient safety, and it helps to prevent errors, improve communication, and facilitate legal and ethical compliance. So let's talk about how that works. Valid signatures ensure compliance with medical record keeping regulations, including those standards set by CHAP and other regulatory bodies. And as I mentioned earlier, if it isn't documented, it didn't happen. And if you did document it and you didn't sign it, then it doesn't count. It's just going to be thrown out. Properly signed records provide accurate, reliable information for all the people that are involved in the patient's care. It helps to reduce the risk of errors. You don't want to have someone unlock a record, have the ability to unlock it, make an alteration, and then relock it. So it's very important. Somebody could go in and either purposefully or maybe by accident do something to really screw up that entry. And that's going to cause a problem. So you have to make sure that when things are locked, they're locked. Accountability and accuracy includes valid signatures to authenticate the author of an entry, which indicates the information is accurate and presents the provider's professional opinion. So we want to help prevent entries from being made by unauthorized individuals or from being misattributed, thus reducing the risk of errors in patient care and signatures. Hold providers accountable for the accuracy and completeness of their documentation. That helps to promote responsible practice. It provides clear communication, timely documentation, and standardization. The next few slides are taken from Medicare fact sheets, specifically for home health and hospice medical review. Now, these guidelines are published for your information and also provide how contractors will audit your documentation. The image on this particular slide is located on page 3 of the medical record and of the medical record requirement fact sheet published by CMS. And the Medicare contractor will request information to audit for compliance. So the type of records likely to be requested is listed on this slide, which includes orders, certifications, referrals, prescriptions, requests for payment, which would be your claims. Home health requires documentation of the certifying provider, demonstrating the need for skilled service and homebound status. Those records must also be properly authenticated as well. Additional information is outlined on page 3 of the fact sheet, which is on the next slide as well. When a Medicare contractor requests supporting documentation for any of these items, physician orders, face-to-face evaluations, therapy notes, assessments, correspondence to and from the patient, a photograph or detailed description of the service or both, and any additional documentation that you need to have to support medical necessity to get paid, all has to be appropriately authenticated. Now, the image on this slide is also located on page 3 of the CMS fact sheet. It's important to comply with HIPAA privacy and security rules. So remember that releasing records to a Medicare contractor upon receiving a valid request related to payment of a claim your organization has filed, it's appropriate and considered business operations, which should be addressed in any notice of privacy practices so that your patients are aware that you use their records for these types of functions. Now, Medicare just came out with an alert that there are phishing scammers. They're emailing and faxing requests for records, and they're not valid. They're trying to get a hold of patients' information for illegal purposes. Anything that doesn't look right, you want to validate the request and make sure that you should be responding. Page 5 of the fact sheet provides a table of what's considered sufficient or deficient access to records requested by a Medicare contractor. But remember, even if you provide everything that is requested, it's going to be thrown out if it isn't properly authenticated. Now, I want to stress something here. And as an auditor, there's something called making sure that you don't release more than what is medically necessary. So you're going to find that under deficient access, providing other documents not requested by the contractor, not specifically directing attention to the requested documentation is deficient access. You don't want to inundate. I was helping with a CMS audit, and we asked for a particular record, and the date of service was over a year old. The provider had it with their cloud service. They sent the request to the cloud service, and instead of sending the records back to that institution or to that provider, they just went ahead and sent everything to the CMS contractor. We got 3 boxes full of documents that we had to go through and look for one date of service. We reported them as a HIPAA violation. So you don't want to give any more, you don't want to give any less. And if you use the cloud service, make sure that they send the information to you, go through and pull out only what's being requested. Don't tick off an auditor by sending copious amounts of information. It is not to your benefit. It will not come out very good. You also don't want to send insufficient information either. On the last page of the fact sheet, which was published December of 2024, less than a year ago, in red, CMS gives us a reminder, you must meet Medicare signature requirements. And the link to this fact sheet that we've been reviewing is on this particular slide, so you can download it for yourself. All right. The Solarian Group Company, or CGS, and National Centers for Medicare and Medicaid provides a web page with links to the Program Integrity Manual that we've been talking about, specifically Chapter 3, and a PDF to download with home health and hospice medical record signature guidelines that you can follow. You're going to want to develop your authentication policies and procedures based on this type of information. Also included on this page is a PDF entitled Complying with Medicare Signature Requirements. We're going to review a summary of these documents covering important compliance points you need to know to keep your patients safe. I'm going to repeat it again, and if I've repeated things over and over, it's because I will be the voice in your head, repeating it over and over, that no one other than the treating provider or the author of the note entered in the record can sign or attest to the entry. That means nobody can sign for another. Case in point, a provider evaluates the patient, documents the encounter in the medical record, leaves the record open, which means failing to close and authenticate the record and lock it. When that happens, you can't file a claim on an open note. And let's say that provider gets hit by a car and is killed. That happened once. I was working with an FQHC and the provider died, and all the records that went unauthenticated, they could not file claims for, and nobody else could go in and authenticate those notes for that person. So until a note is signed and locked, it leaves the encounter vulnerable to being altered by someone else. And because it's a legal record, we have to safeguard it against falsification. Signature requirements, the standard is either handwritten legible signature, or if it's illegible, the organization can produce a signature log to identify who the author is. We're going to review signature logs, when and how to create them before we're done, along with the attestation statement that CMS allows. CMS does permit the use of a rubber stamp. Rubber stamps used to be very popular. Doctors used to use their rubber stamp on prescription pads. Well, prescription pads shouldn't be laying around anymore. We've really sophisticated e-scribing. And if you do have a rubber stamp because you have someone with a disability that is a provider, and they fall under the description under the Rehabilitation Act of 1973, and they can use a stamp, you need to provide proof to a CMS contractor of the inability to sign, as well as your policy on how you keep that signature stamp secure from inappropriate use by others. And by affixing that stamp, the provider is certifying that they've reviewed the document and the information is true and accurate, just as if they had signed it. Whenever possible, download and implement guidelines provided by CMS. This slide provides a snippet of the signature guidelines for home health and hospice medical review. We're going to review parts of the guide right now, but this is the link where you can download it yourself. CGS Medicare has a table on page 2 of their signature guidelines fact sheet, and Medicare contractors use this when they're reviewing your claims. It's important to share this with you so you can audit in a similar way to your payers. When the table indicates to contact a provider, it means the audit contractor is questioning the validity, and they're going to ask for additional information. It's an additional development request or an ADR, and you only have 15 days to respond. Now, 1 through 5, they all are acceptable. So if it's a legible signature and a legible first initial and last name, they'll take that. If credentials are required for the type of entry, you need to make sure that's there too. And legible signature over a typed printed name is good. And a legible signature not over a typed printed name and not on a letterhead, but submitted accompanied by a signature log or an attestation, they're going to take that without question. Now, the audit contractor is directed to contact a provider when an illegible signature lacks an appropriate remedy, as reflected in 6 through 9 here. So if there's no signature log or attestation statement that's submitted with the documentation, they're going to contact the provider for an ADR. And the same with initials. With no signature log or attestation, they're going to submit an ADR. You have 15 days to turn it around. It's not a lot of time. 10 through 14, there are 4 out of the 5 issues where an ADR is going to be generated. And the only acceptable one, unsigned handwritten note, where other entries on the same page in the same handwriting are signed. So they do a reasonable test, and they're being reasonable in this case. But all the other unsigned notes, they would generate an ADR. When you find that the credentials are missing from the signature date, or that the signature is missing entirely, you cannot add a late signature. CMS will compare. Let's say you submitted documents and there's no signature or there's no date on it. And then they turn around and deny the claim. And then you submit the same documentation on an appeal, but you've added a signature or you added the date. They compare. Even if it's a different contractor, they'll compare and they'll say, you altered this, you added this late. That could lead to an investigation of your authentication policies, and it might not end well for you. So you got to make sure you don't do anything like that. You're going to use an accepted remedy. If the signature is missing from an order, the order is going to be disregarded during the review of the claim. So as much as we strive to care for our patients and in the hurry of trying to get administrative work done, which is a real pain, and we're trying so hard, we're all overworked. An entry, it occasionally can go unsigned or an invalid statement or signature applied. If there isn't a remedy for all situations, but there are a couple of solutions that Medicare accepts. Other payers may or may not follow these specific guidelines. So first, the signature log. It can be created at any time. I suggest you keep a signature log that for all new on boards. Anybody who has the ability to make a medical record entry should be listed on here. You put their typed name, any kind of credentials they have, and then you have them scribble their signature that they normally scribble, because a signature log scribble needs to match the scribble in the medical record when you produce the signature log to accompany it. The same with the initials. This is a sample of an attestation. If you don't have a signature log, but the provider is still available to sign the attestation. So it would be like, I, John Doe, hereby attest that the medical record entry for Jane on 10/1 of 2024 accurately reflects signature notations that I made in my capacity as an MD when I treated and diagnosed the above listed Medicare beneficiary. And then the other, they attest that the information is true, accurate, and complete. And then they need to sign this. When I have done CMS audits, they fill everything in and the provider forgets to sign the form. So the attestation gets thrown out. So don't send in an unsigned attestation form. That's a common problem. Your organization may already have a policy, but if you don't, it's really wise to document one in the event that you are requested to produce an electronic e-policy. This is if you use electronic records at all in your organization. Now, it's to help to ensure your EHR software and hardware have protections against e-signature modifications and that they meet current signature laws and supports your policy. So why would a payer, and specifically CMS, request your e-policy? What happens if you don't produce it? You don't want to find out. Medicare has denied, and only on appeal did people get paid. They being CMS, uses your e-signature policy for audits and reviews to make sure that nobody else is signing for the providers. So audits, reviews, and verification of compliance to secure e-signatures. When you create an e-signature policy, safeguards need to be in place to protect against unauthorized access and inappropriate use of your electronic signatures. And it doesn't matter by what method. It can't be by anyone else other than the designated individual to whom it is assigned. So it needs to be unique to the individual, not reassigned nor reused by anyone else. And the measures need to be in place to protect the links between electronic health information and signatures, which prevent unapproved alteration through either removal, copying, or transferring. To avoid unnecessary payment denials, rejection, or overpayment situations, I really strongly urge providers to check with their technical staff or software vendors to verify that the current medical record keeping and signature processes are in compliance with CMS instructions, and it should meet or exceed industry standards to avoid compromising the integrity of documentation and signatures. A few tips when generating your policy. It needs to be written. You need to train all the staff on the signature policy and maintain accurate audit logs within the EHR to track all electronic signatures and to ensure that nobody's unlocking, altering, and then relocking the records. This is also for HIPAA compliance as well. Using alternative signature methods such as digitized signatures, ensure that they're compliant with CMS guidelines and have appropriate security measures in place. The next several slides show what to include. Authentication methods used to authenticate. If you use a third-party vendor that provides your e-signature software, you want to show that in your policy that you require a business associate agreement. And for digital certificates, when you're using digital signatures, it should address the use of the certificates for identity management. Next is how your policy should ensure electronic signatures are clear and reliable, similar to handwritten signatures, which should mirror your handwritten policy. And if you don't have a handwritten signature policy, you should have one. Policy should demonstrate how the integrity of the document is maintained after the signature is applied, preventing unauthorized alterations. You also want to address how to ensure the signer cannot deny signing the document, referred to as non-repudiation. This is often achieved through time-stamped audit trails. We're not done. There's a few more things that I want to go over, which includes how your system safeguards against misuse by describing measures that you have in place to prevent unauthorized access and use of electronic signatures, such as you want to address password protection. Your policy should clearly state that the individual whose name is on the electronic signature and the provider bear responsibility for the authenticity of the information. You're going to want to use that type of wording. And the last is record retention. This refers to writing your guidelines for record retention, including the electronic signature audit trail. Your policies, there's medical record retention policies, there's HIPAA documentation retention policies, which is 6 years. CMS is 5 years. If you are managed care provider, I believe it's 10 years. And whenever you have internal policies and procedures, you want to keep it. My recommendation is keep it for 10 years or archive it and keep it forever, because you could be investigated. They could go back for years and you want to show that you are doing what was correct according to the guidelines at that time. Because you know how things evolve and things change. So you always want to keep past policies and procedures handy. So in conclusion, let's avoid potential legal challenges, never print anything that can be construed as altering a document, including backdating entries or adding late signatures. It could lead to accusations of fraud and professional misconduct, making it difficult to defend against malpractice claims. Now, deliberate falsification of medical records, which includes backdating entries, is a felony offense with serious consequences such as fines, loss of medical license, and even criminal charges. When a discrepancy is discovered, such as a note signed much later than the documented visit, it can raise doubts about the provider's credibility and the accuracy of the entire medical record. Waiting a significant period to sign notes increases the risk of forgetting the details about the patient's encounter, potentially leading to inaccurate or incomplete documentation. Be compliant to billing requirements. Medicare and other payers require accurate and timely documentation for claims to be valid and for services to be verified. Late signatures can jeopardize reimbursement, even if an attestation statement is added later. Denise, this ends my presentation, and I don't know if we have any questions, but I'm available for Q&A.
We do. We have some great questions here. I'm going to kind of start from the most recent one, as it's likely something you've just hit on. So the most recent question was asked, and it says, can a claim be submitted if there are unsigned orders within the claim period?
That is a really good question. If the order is required documentation for you to get paid for a particular date of service, then you should not be submitting the claim. Because I have audited for CMS, and let's say it's an order for a plan of care or physical therapy or for whatever. And that piece of documentation needs to show medical necessity for a particular date of service. They will deny that date of service that your organization provided that service because that order wasn't signed.
Thank you. Okay. I've got a few more here, so I'm going to just kind of go through them. How should you handle it if the patient has an attending MD and also the hospice medical director / IDG physician are different doctors? The hospice medical director signs an order and you send out a fax courier order for the attending to sign the order, and they take their time about signing the order and sending it back to you. Any best practice ideas around that?
It is very hard to get downstream signatures timely. The best thing to do would be to just keep following up. I wish there was a good solution for that, but at least you do have the hospice medical director's signature. And that goes a long way, even if it's a delayed signature that you end up getting from the PCP of the patient. Let me think about that. And if I come up
Okay.
with a solution for you, I'll let Denise know.
Thank you.
That's a good
Okay,
question.
on the CGS website, it states that for an electronic signature, in addition to a date, they state that a time is also required. Is including a time the latest guidance by CMS as well?
It depends on the type of service that you're rendering. Time can be a requirement depending on the type of claim that you're filing. In general, CMS does not require things to be timed. They do for psychiatric notes where you have to have the amount of time. It would be easier if I knew what type of claim you're referencing.
Okay. What I am going to do, just so that everyone here knows, we will end on time today, but I'm going to put the contact information for the American Institute of Healthcare Compliance in the chat. So if you want to send your question with some more details, you would be able to do that that way and then get a more thorough response to that question. One more thing here. I'm so sorry. We have one question here. Is the clinician's signature invalid if it's illegible, but the electronic signature that's seen underneath the illegible signature, which includes a clear name and credentials, as well as the time and date stamp present, is that acceptable?
You're good. That's
Okay.
good.
Thank you. I will this one more, and then I'm going to close this out for the day. If the hospice medical director signs their name but routinely neglects the date in the signature, is it an acceptable practice to have a policy for clerical staff to use a date stamp to show when the document was signed?
No, nobody else should be dating that. You need to train that provider to date, or give the provider the date stamp, but have a policy that the only one that uses that date stamp is the provider that is authenticating the note.
Okay. All right. Well, thank you to everyone who submitted a question. If we did not get to your question, I am right now posting the link to the contact us on Joanne's website. There are, Joanne will be reviewing those questions as they come in, as well as some of the other staff that will be there as well. So they can provide you with a thorough answer to your questions. I recommend utilizing that as a resource. I just want to say thank you to all of you who joined us today. As I mentioned before, you will receive a link to the recording if there's anything here you want to revisit. It was a wealth of information, so I know that there might be things you do want to rewatch. And to Joanne, we just want to thank you so much for putting this together for us and taking the time to join us and bring us your expertise on this subject today. We really appreciate you being here.
My pleasure.
All right. Thank you, everyone. Have a great rest of your day.
Thank you, everybody.